Welcome to today's clinical pathology session. Today, we're tracking the diagnosis and pharmacological management of imported Plasmodium falciparum malaria through a specific clinical case. Our patient is Marcus, a 52-year-old petroleum engineer. He recently returned to the United States after a 4-week trip to Nigeria to visit family and friends. This diagram outlines his clinical timeline. Exactly 12 days after his flight landed, Marcus presented to the emergency department. He developed a sudden onset of high fever, peaking at 104.2 degrees, accompanied by profound rigors, a severe frontal headache, and deep muscle aches. This timeline is highly specific: a 12-day incubation period followed by an abrupt, intense systemic paroxysm strongly points toward a parasitic infection. When any patient presents with an acute febrile illness shortly after returning from a highly endemic region, clinical guidelines dictate an immediate presumptive workup for severe malaria. There is a clinical paradox in Marcus's history. He grew up in Nigeria, an area where this pathogen is endemic. Why didn't his immune system protect him? Marcus made a critical clinical error. He assumed his childhood exposure granted him permanent immunity, and because of this, he bypassed pre-travel medical counseling and skipped chemoprophylaxis entirely. The epidemiological reality of naturally acquired immunity to Plasmodium falciparum is that it is highly conditional. This chart illustrates the timeline of naturally acquired immunity. Protective antibody titers are transient. They require continuous, repeated exposure to infected mosquito bites to maintain their levels. During his prolonged residence in the United States, far from endemic transmission, Marcus's partial immunity decayed, leaving him highly susceptible to a new infection. This map shows the exact scale of the risk. West Africa is a hyper-endemic zone, accounting for roughly 70% of all imported malaria infections diagnosed in the U.S. The immunity myth strips returning travelers of their protection, exposing them to life-threatening infections. Rigorous pre-travel counseling and prophylactic medication are absolute medical necessities. Initial routine laboratory work in the emergency department revealed mild thrombocytopenia and anemia. To rapidly narrow the differential, the attending physician ordered an immediate rapid diagnostic test, or RDT, to screen for circulating Plasmodium antigens. Looking at the RDT results, we see a distinct positive line for the pan-malarial aldolase antigen, confirming an active Plasmodium infection. Directly above it, a second line appears for histidine-rich protein 2, a biomarker highly specific to Plasmodium falciparum. While these biomarkers provide a strong presumptive diagnosis, the clinical standard requires light microscopy for definitive confirmation and to quantify the parasite burden. This thin blood smear reveals normal-sized erythrocytes containing multiple delicate ring-form trophozoites per cell, the visual hallmarks of falciparum. His parasitemia is calculated at 2.5%, achieving these higher burdens by aggressively invading red blood cells of all ages. Despite the high fever, Marcus remains alert. He has no altered mental status, acute kidney injury, or pulmonary edema, ruling out severe malaria. The positive HRP2 antigen combined with this specific microscopic morphology gives us our definitive diagnosis: acute, uncomplicated Plasmodium falciparum malaria. We need an immediate, targeted pharmacological intervention. The historical gold standard for treating this infection was chloroquine. Why isn't it the first-line choice today? For infections acquired in West Africa, chloroquine is now clinically obsolete. Decades of widespread administration created immense evolutionary pressure, selecting for parasite strains that carry a specific mutation in the PFCRT gene. This genetic mutation alters the chloroquine resistance transporter on the membrane of the parasite's highly acidic food vacuole. In resistant strains, this mutated transporter functions as a high-speed efflux pump, aggressively capturing charged chloroquine molecules and violently expelling them. By pumping the drug out so rapidly, the chloroquine never accumulates to threshold concentrations needed to inhibit the biocrystallization of toxic heme. Prescribing chloroquine monotherapy in this clinical context allows uninhibited parasite replication, leading directly to catastrophic treatment failure. To overcome this regional resistance, the World Health Organization mandates oral artemisinin-based combination therapy, specifically a formulation known as Coartem. This timeline illustrates the strategy behind the combination. It pairs a rapid-acting vanguard drug with a longer-acting sweeper drug to attack the parasite on two fronts. The vanguard component is artemether. It acts as an exceptionally potent but incredibly short-acting blood schizonticide. Artemether passively diffuses into the infected red blood cell, accumulating heavily within the parasite's highly acidic food vacuole. The drug contains a structural detonator, an endoperoxide bridge. Upon physical contact with free ferrous iron generated by the parasite's digestion, this bridge cleaves open. This diagram shows the catastrophic downstream effect. The cleavage unleashes massive, carbon-centered free radicals that violently alkylate vital proteins and tear physical holes in the parasite's internal organelles. Artemether turns the parasite's iron-rich metabolic engine into a self-destruct mechanism. A single 48-hour exposure cycle achieves an immense 10,000-fold reduction in total parasite biomass. But artemether has a critical vulnerability. Its elimination half-life is under 1 hour. If used alone, the tiny fraction of surviving parasites would inevitably cause a clinical relapse. That is why it is co-formulated with lumefantrine. Lumefantrine is the sweeper, featuring a prolonged 3 to 6 day half-life, designed to maintain sustained therapeutic blood levels. Lumefantrine executes a distinct mechanism of action, selectively binding to the highly toxic free heme produced during hemoglobin digestion. This newly formed drug-heme complex physically blocks the heme polymerase enzyme, preventing the crystallization of waste into safe, inert hemozoin. Here, we see the immediate biochemical consequence. Unable to process its waste, the parasite suffers a massive, lethal accumulation of cytotoxic heme and reactive intermediates. This severe oxidative damage destabilizes and destroys the vacuolar membrane. The parasite is effectively poisoned from the inside out by its own food source. The vanguard drug rapidly neutralizes the acute symptoms, but it is lumefantrine's sustained biochemical blockade that eradicates the residual survivors and secures a definitive cure. We must translate these molecular mechanisms into strict clinical orders. This timeline lays out the standard 3-day dosing architecture for Coartem. Marcus takes an initial dose immediately, a second dose 8 hours later, and then twice daily on days 2 and 3. Notice the pharmacokinetic imperative. Every dose requires a high-fat meal or milk. Lumefantrine is a highly lipophilic compound. Co-administering it with dietary fat increases its relative bioavailability 16-fold. Without it, the drug will fail to reach the concentration threshold required to block heme polymerization. Marcus adhered strictly to the 3-day regimen. Serial blood smears tracked his progress, confirming rapid clearance of parasitemia and fever within 72 hours. This brings up a common clinical question regarding malaria follow-up. Does Marcus require post-treatment anti-relapse therapy, often referred to as a radical cure? This diagram shows the biological distinction. Plasmodium falciparum relies entirely on the erythrocytic blood cycle. It completely lacks a dormant hepatic phase. Because there are no dormant liver hypnozoites waiting to re-emerge, unlike infections with Plasmodium vivax or ovale, post-treatment drugs like Primaquine are completely unnecessary. Meticulous travel history, rapid biomarker identification, and targeted pharmacology constitute the gold standard for saving lives in cases of imported falciparum malaria. The clinical case of Marcus is now concluded.